Hello, Kidney Warriors. James here from Dadvice TV, your online kidney health coach. And this is Dadvice TV Live, episode number 102 in my journey from kidney failure to kidney great. Now, for those of you that are new, like Daisy, hey, say hello in the comments. Hey, Daisy, welcome here. We have a great community and we help each other. We support each other. And a lot of times you may have a question and somebody in the audience had that same question and they can share, hey, here's what worked for me. Here's what I asked my doctor, things like that. So it's great for all of us to work together. Now, if you are new here, one of the first things you need to do is click that little subscribe button on YouTube so you will get a notification every time I upload something new or do a live broadcast like this. Look at it. We also have Charo here new. Welcome. Always great to see so many new people each time. Oh, wait a minute. There is my old great friend, Candy. Candy, hey, glad to see you. Candy is an old friend of mine from the late 1990s. And we just reconnected today on LinkedIn. For some reason, I was on there and I saw her and we started chatting. And she has, I believe it's her daughter or somebody, is on dialysis, has kidney disease. She said, I'm going to be there. I want to learn about kidney disease. Now, for those of you that are new, my name is James. I am not a doctor. I'm just a regular person like you. Now, I wasn't being very good with my diet. And one day I got sent to the ER. Things were really bad. And I can hear some crunching in the background, just so our guest knows.
Sorry.
I told him, I said, hey, your mic's hot. Remember that. He hasn't had dinner yet. But I got sent to the ER and I spent a week in the ICU with kidney failure. My GFR, the doctor's got it up and stable at 13 and told me that's as good as it's going to get. You need dialysis or a transplant or things aren't going to look too good for you in the future. And you're not going to be around very long. Well, I never went on dialysis. I never got a transplant. Instead, I had some luck on my side, and I am a super nerd up here. I started reaching out to doctors, doing all sorts of research. That very day, sitting there in the bed, in the ICU, I changed my life. I decided, you know what? I'm going to do whatever it takes to try to delay or avoid the need for dialysis. And I started working with renal dietitians, my healthcare team, all of them. I got them all in sync. And we worked and I started improving. The last time I got my kidneys checked, GFR 33. Very excited about that, but really, I don't care about the GFR. What I care about most importantly is how I feel. I do not have a single symptom, and look at this, full of energy. I have my life back thanks to simple changes and working very closely with my healthcare team. Now with me, we have an important part of the healthcare team. We have a genuine nephrologist all the way down in Texas, everybody. Welcome, Dr. Butt. Hey, Dr. Butt, how you doing?
What's up, man? How you doing?
Hey, doing great. For those that are new, tell them a little bit about yourself.
Well, I'm Dr. Qasim Butt. I'm a nephrologist, kidney doctor out of San Antonio, Texas. I'm pretty active on social media, so if y'all could do me a favor right now, like my page on Facebook, LinkedIn, and also follow me on YouTube. I have a channel there called Your Kidneys, Your Health, where I do kind of concise videos on kidney health. They're about 3 to 5 minutes long, but you learn a lot. And I'm sorry for the earlier chewing. I was eating my kidney-friendly diet, just so you know, and I couldn't resist. So.
And for those of you who have not seen his videos, I think they are hilarious because they're not boring. It's not a doctor in a lab coat in front of a PowerPoint or anything like that, like you guys have seen plenty of on YouTube, and it's hard to stay awake and figure out what they're saying. Dr. Butt uses English, that we can understand. He's not talking over our head with medical terms and medical jargon. It's easy. It's to the point. He keeps the videos engaging. He dresses up sometimes to kind of, one of them you're eating a sundae. I can't remember what one that is. Yeah, I was telling you
what not to do, but yes, I was eating a sundae.
He's telling us what not to do, yes. So his videos are hilarious, so make sure you do subscribe to his channel and follow him on Facebook. The more great information, the better off you will be. Now, for today's topic, we're going to talk about something that practically every single person on here, I'd be surprised if there's anyone on here who doesn't have kidney disease, went through. pretty much being told you have kidney disease. Now what do I do? We're going to answer that question straight from the doctor. Whoops, wrong way. My screens are mirrored here, so I got to remember it's opposite. Right from the doc over here. What do you do when after you get diagnosed? What are the next steps? We're going to talk about treatment. We're going to talk about all sorts of great stuff. Now, if you guys have a question, this is a live chat. Let's pop up someone. We got Candy, who just said, "I subscribe, doc." See, right there,
awesome.
It just happened.
Awesome.
Feel free, ask questions, and I will try to squeeze the questions in during the conversation. And near the end, at the top of the hour, I go through and I try to find any that I missed, and I'll ask the doctor about it, and we'll get his opinion. Now, we can't diagnose or treat anybody right here on YouTube, but we can answer questions, help put you in the right direction. And sometimes it may be a little general. You can't post a question like, "Hey doc, my bun is 48, my GFR is 31, my creatinine is 2.52. What should I do?" That's a little too much like diagnosing and treating. But you can say, "Hey, if I need to lower my bun, what are some things I can do?" Questions like that are great. So let's go ahead and jump right in, doc. I've just been diagnosed. I'm confused. I know nothing about it. There's a lot of stress. Depression sets in, and most of us end up going to Google or to Facebook, and we look up stuff, and it's all scary. And I tell you, myself, I went through this, and I speak to so many people that went through this. We go home from the doctor's office. The doctor may have said some stuff. What we heard was kidney disease, dialysis, transplant. That's kind of what we heard. And diet was in there somewhere. What should we be doing first, or how do we get a hold of this?
Well, the first thing is, honestly, I think, and this is key to any situation, is to get educated, right? I think you have to get educated, and by education is not just Googling a few things or YouTubing a few things. It's actually starting to research what kidney disease is about, what it means, and also what the labs mean. So I would start off with what the labs are, okay? So right off the bat, what I would do if you were told I have kidney disease is ask two things. What's your creatinine? What's your eGFR? Okay, so your creatinine, a baseline creatinine is supposed to be between 0.8 and 1.2. That's kind of average. It varies per person, but that's what you want to know. Where's my creatinine relative to everything else? Okay, so with creatinine is the higher, the worse. So the more creatinine you have in your bloodstream, the less your kidney is cleaning out that creatinine. Do you see what I'm saying? Yep. So I have people that have a creatinine of 2.0. That means their creatinine should be around 1, but that means their creatinine is not getting cleaned out of their blood and it's developing and it's staying at 2.0. Do you see what I'm saying? So that's the first thing. What's my creatinine? So you got to understand that. The other thing you got to understand is eGFR. What is eGFR? eGFR is the estimated glomerular filtration rate. Okay. What that means is how is my kidneys filtering? What percentage are they filtering? Okay. A normal eGFR is anywhere from usually above 100 to 120, 140. Okay. That's a normal eGFR. So for estimation purposes, we just say percentage. Okay. That's what I tell my patients. So you look up what an eGFR is, you ask them, what's my eGFR? What's my creatinine? Okay. Now, if you're probably in a kidney disease, you have kidney disease and you're seeing a nephrologist, your eGFR is likely less than 60, likely. Okay. Although you can't have a GFR greater than 60, you could be CKD 1 and 2. Which is a higher level of GFR, but still have other issues going on that qualify you to be called kidney disease or CKD. Okay, so start off, know what those labs are, and then what you're going to do is you're going to ask your doctor those labs every single time you see them. Okay, and in fact, you can ask those labs to your PCP because typically your PCP is doing those labs anyway. They're checking. Yep. Your chemistry panel, and they're checking your kidney function anyway. So every time you get blood work done, you can say, "Hey, what's my creatinine? What's my eGFR?" Okay. So that's the first step. That way you kind of gain power. You can kind of gain understanding that, hey, my kidney function is at 45%. That's where I live at. So that's it. So now
I have a couple questions there. Or a couple. Yeah, go ahead. So the first point is, just so that everyone understands, does GFR go down naturally with age?
Yes.
So is somebody with a 70 as healthy as someone who's 20 with a 70? with their kidneys?
No, that's not it. So yeah, exactly. So it's relative. And creatinine is a number that is completely relative. And just so you all know, creatinine is a reflection of your muscle mass. Okay, that's what it is, a reflection of. It's a breakdown of muscle tissue. We just happen to use it as a marker for how well your kidneys are filtering. You understand what I'm saying? So people that have a higher muscle mass, that includes younger people have a higher muscle mass than older people, right? So males have a higher muscle mass than females. And if you look at the calculation, you'll see on the lab EGFR African American and non-African American. Blacks in our country have a higher muscle mass than other people. So the GFR calculation has to be adjusted for their creatinine number. Do you see what I'm saying?
Yep.
So you have to actually take that into account. So again, if you're Black, African American, you have a different EGFR, and so a little bit off. So you can actually, as a Black person, have a higher creatinine and still have a better EGFR than, say, someone at the same creatinine. Do you see what I'm saying?
Yep.
And also, like what you said about age and kidney disease. Yes, as we age, your kidney function naturally comes down. Okay, it just does. So your creatinine is actually supposed to be less at a later age. And so a creatinine of 1.2 in myself as a 40-year-old male is not bad. But a creatinine of 1.2 in a 70-year-old white female could be CKD stage 3 or even 4, depending on how much muscle mass they have. Yep. So in general, yes, creatinine, your kidney function does decrease with age, but generally it should stay above 60 generally. Okay, now sometimes it can go down to the 50s, but it depends on your overall health status too. It's not like it does decline, but if you have diabetes, high blood pressure, that EGFR is going to decline faster.
Now, when I was first diagnosed, my doctor and we had a lot of very blunt conversations. And
James, before we go, I just realized we're completely too matchy on this. We look like we're wearing the same.
Except you're missing the Dadvice TV logo.
But I got my name on here, man. I got my name. So I got my name on here. So mine's a little bit more official. So go ahead.
So when I was diagnosed, of course, I'd done a lot of research, as much as I could when I was first diagnosed. So it's a waterfall. It's a tsunami of information. It's hard to figure it all out. And I was set on, I'm going to lower my creatinine because then my GFR goes up and I'm doing better. And my doctor said, no, James, don't focus on your GFR. We look at the creatinine as a reference that something is wrong. But you got to look at all your labs and how you're feeling. And what are your thoughts on that? Because I find so many people, especially when they're first diagnosed, are focused on, I have to lower my creatinine. That's the goal. Instead of, hey, I got to make sure everything else is good, take care of anemia, get my blood pressure, my blood sugar, and all your other labs, my sodium and all that in check.
Yeah. And you're absolutely right. So yes, you want to get your creatinine down, but the way you get it down it's not like one magic pill is going to bring your creatinine down. So like yourself, you took it upon yourself to make behavioral changes. And so when you made those behavioral changes, that in itself started lowering creatinine. So there's no magic bullet to bring your BUN down or creatinine down. It's really a change in lifestyle, following medications, getting your diabetes, high blood pressure under control. And I think I told you before, or getting off medications that are hurting your kidneys, like yourself. Yes. Doses of ibuprofen, Aleve, Advil, those kind of NSAIDs that we call them. If you're on high doses of those, that can actually decrease your kidney function. So you want to get off of those, and then you see sometimes you get a good recovery. So you can see that happen. But again, it's not just about that lab. You can't just look at the lab. You have to look at the complete person, getting yourself better. And I've seen it too, where if someone's very anemic, and anemia is measured in something called hemoglobin, y'all may want to look at what your hemoglobin is. Now, if you're a CKD patient, a kidney disease patient, you want your hemoglobin above 10. A normal person like myself has a hemoglobin of 12, 13. Okay, that's a normal. But your kidney disease patients, you want to keep them above 10. But I've seen people have GFRs, hemoglobins of 7. And then when you get their anemia fixed up, that kind of gets them a little bit better, and sometimes their kidney function actually improves a little bit depending on what was the cause of the kidney failure. So I've seen that as well too.
Yeah. So now here's a great question. Why is it that so many doctors wait until your GFR is below 60 before telling you that you have some kidney issues?
Okay, so the diagnosis, it depends on the doctors. I realize the old school doctors kind of refer later than the younger school doctors. So the younger doctors do refer earlier. But if you have a GFR of greater than 60, let's just say it's 65, and you're 65 years old, I wouldn't necessarily call you CKD unless you had either blood or protein in the urine. So you technically can have CKD even if your GFR is above 60, but that's usually indicated by either blood or protein in the urine. Okay, so you definitely have CKD if it's less than 60. You definitely have it. But if your GFR is above 60, 70, and you have blood or protein, that's definitely a sign of it. So a lot of times it depends on the primary. The primary doctors sometimes want to be the quarterback, and they are the quarterback. They are. They don't want you seeing 20 specialists for minor problems. So that's probably why they're sending out, because you don't want to see another doctor, right? Unless you have a serious problem. And the thing is, I would say GFR less than 60, you definitely need to see a nephrologist. If you have any blood or any blood protein in the urine, you need to see a nephrologist for sure.
Yeah, I'll tell you, I had this, not to get gross, but the blood in the urine was an early symptom that I ignored. I just thought, hey, it's age. Something's wrong. I don't feel like going to the doctor for this. Let's see if it clears up. Give it a couple of weeks and see what happens. I should have called my doctor instead of waiting until I had to go to the ER. So it's important not to ignore any of those symptoms, everybody out there. If you've got a symptom, something just doesn't feel right, let your doctor know, and don't be embarrassed by it. I was actually embarrassed. I was like, I don't want to talk about bleeding urine.
It goes beyond just letting your doctor know. I've noticed that a lot of people don't even want to go see the doctor. They'll just be like, oh, I'm feeling fine. Oh, I'll get over it. That kind of thing. I think it really starts with you kind of taking your health seriously. And, on a regular basis, not a regular, but like if you're relatively healthy or you think you're relatively healthy, at least go for your annual checkups. And on your annual checkups, they'll check your kidney function. You see what I'm saying?
Yep.
And if you're really diligent, you really want to know about your urine, about your kidneys, you can ask them, can you check the blood or protein in there? And that's it. And they can tell you that.
And that's a urine test, right? To find out.
Yeah, so it's called a urinalysis. So typically on a urinalysis, they'll tell you if there's any RBCs, red blood cells in there, and also tell you if you have any protein in there. And if you're a diabetic, you know what? If you're a diabetic, anybody here diagnosed with diabetes or pre-diabetes, you make sure they're checking your urine for protein, any signs of protein, because that's a sign of damage. So protein is like the damage that's happening in there.
Yeah. Now, is it possible? This is a great question Beverly asked, and I've actually never seen this question asked before or read it before. Can you get kidney disease of just one kidney, or is it always a both if you have two?
So typically the kidney disease we're talking about, like diabetes, high blood pressure, vascular disease, or even like yourself from like high doses of certain medications, that's attacking both kidneys. So any systematic disease is affecting your whole body. And so it's likely affecting both your kidneys at the same time. Now, there are people that have, say, a kidney cancer in one kidney. You see what I'm saying?
Yep.
Or they're born with what they call an atrophic kidney, where one kidney is like a prune and the other kidneys are nice and healthy. So there are diseases out there, or you had a kidney stone in one kidney and that kidney stone lodged in there has damaged that kidney more. So it's a possibility that you can't have one more than the other. But in general, it's usually both that are affected. And when you're getting that creatinine calculation and the eGFR calculation, you're getting it based off of how well both your kidneys are working. So it's no way to assess one or the other.
Yep. And one question that's related to this, I'd definitely like to have you chime in on it. Is kidney disease hereditary?
Well, yes, it can be. So one disease, particularly polycystic kidney disease, I don't know if you heard of that before. It's literally a disease where you have a massive amount of cysts that form. A cyst is like a bubble that forms in an organ, a little bubble, okay? Now, as we age, I may have a cyst or two in my kidneys, maybe in my liver. It's a possibility that you form these cysts. But what happens in a polycystic kidney disease is you have a massive amounts of these cysts, dozens or even hundreds of them, where there's so many bubbles in your kidney that they actually take up a lot of space and destroy the tissue of the kidney. Do you see what I'm saying? Yep. So that's one way it can be. The other way I would say is if you're someone whose family members are on dialysis from diabetes or high blood pressure or vascular disease or circulation issues, guess what? You're probably predisposed to the same outcome. So if you're someone whose mother is 60 years old is on dialysis and you're 40 years old or 35 years old and you have diabetes, and she has diabetes, then guess what? You're probably more predisposed to going on dialysis too. So, there is that component there. Not everyone who's a diabetic winds up on dialysis or with kidney disease, right? But if you have a family history of people having diabetic nephropathy, which is diabetes in the kidney, then you're probably a high likelihood of getting it as well too.
Yeah, and my mom has kidney disease. She's stage 3. And I saw a question posted by my dad. I know it will be on behalf of my mom. Does an occasional beer help cleanse your kidneys?
She what? Oh, doesn't a occasional beer to cleanse the kidneys?
That's my dad. I'm sure it's on behalf of my mom.
He thinks the alcohol is just kind of cleaning out the kidneys. Is that what it is?
I think so. Yeah. No beer, Dad or Mom, and no Snickers or anything like that. Those need to go. We need to eat healthy. Oh, darn it! I had a great question, and now I forgot it because I saw my parents' post there go by. Darn it. Well, I will remember it later. So now I've got my EGFR, I've got my creatinine level, and from the description today, we kind of better understand it. What's next for me?
So the next thing you want to know is, okay, after you know the creatinine GFR, is to make sure your urine is checked, right? So you can have your urine checked, and once you have your urine checked, you can ask them to tell you if there's any blood or protein in there, okay? So any blood or protein in there is a sign of active disease in your kidneys. Do you see what I'm saying?
Yep.
So your kidneys are a filter. They kind of clean your blood, right? They put this bad stuff out and they keep the good stuff in. Well, guess what? Blood and protein are the good stuff you want to keep in, right? So if you're spilling blood or protein in the urine, that means there's holes in that filter. And so those holes were created and they're spilling those out. So when you're seeing that either blood or protein in there, that's telling you what's going on. Now, if you have a lot of protein or a lot of blood, that's a sign of active disease, active something going on. And so that's how you would know, that something is going on.
Yeah, and I'll tell you, when I had my blood, it was like solid. It looked like all I was peeing was blood. And I ignored it. It probably was maybe 4 or 5 days later when I ended up going into the ER, and I kind of wish I would have just said something to my doctor. Here's a great question just popped up. Kathy asks, can a longtime type 2 diabetic older person stay in stage 3 or even improve?
I think I don't know. They can definitely stay the same. I have patients that literally have a GFR of 40 to 35. And again, just so you all know, with the creatinine and GFR, you got to remember we're human beings. We're not set numbers. So you're not always going to have a creatinine of 1.5 or a GFR of 32. You're going to kind of fluctuate. So if you see your creatinine is 1.5 today and then 3 months from now it's 1.6 or 7, that's not necessarily a worsening of your kidney function. It could just be the normal fluctuation of having kidney disease. But I have numerous patients. That's why you go see a nephrologist, because the point of seeing a nephrologist oftentimes is, we get them late in the stage, late in the game sometimes, but it's not necessarily to bring the kidney function from GFR from 45 to 70. Sometimes it's just about maintaining. Yeah. Right? Keeping that kidney function stable. And the way we do that as nephrologists is we make sure you don't go on any bad medications that hurt the kidney, like ibuprofen, Aleve, Advil, but also certain antibiotics, or avoid certain antibiotics. But also make sure you're on certain medications that are beneficial to your kidneys. Make sure your diabetes and high blood pressure is controlled. And that's how we kind of help maintain those kidneys over time. So yes, you can have decreased kidney function. You can be CKD stage 3 till you die. But it is on you to help control it.
Yeah, and my doctor, he told me, don't focus on that GFR because it will fluctuate, and it did. Sometimes it fluctuated because I did something bad. Like I changed my diet drastically. I tried a very bad version of keto, and my doctor said, don't do it, and it went down. And then he said, go talk to the dietitian. She'll get you straight. Got it, and then it started going back up over time. As I was eating better for my body. But that is an important thing to know. It's going to fluctuate. And he told me, let's focus on the symptoms. I had severe anemia, the headaches, unable to sleep. Let's focus on what we can do to address those so you feel better. And I'll tell you, I was so happy when I got somewhere in the upper 20s. I remember the day. I didn't have the labs that day, but I remember the day when I was actually recording a video, and I realized, you know what? I actually feel really good all day today. Something has changed. I've crossed some line. You know, things were slowly getting better, but I realized, holy cow, I've been up all day running around. I'm not exhausted. I've crossed the line. And that was just so helpful for me as a person. And that is something that kept me going with, okay, I'm going to stick with this diet. I'm going to do what the doctor says. I want to make sure never to miss my blood pressure meds. You know, I'm going to do what I need to do because of that. I remember that breaking through that moment and feeling better. And ever since then, my GFR has continued to go up some, but I feel the same. I just have lots of energy. I feel great. But I do remember the day that something happened while I was asleep. You know, I guess I just got the symptoms subsided enough to where I felt, to me, amazing compared to what I used to feel like.
Yeah, well, your anemia probably got better, and then also GFR, just by getting better, the toxins are kind of being cleaned out of your blood a little bit better. So all of a sudden you start to feel better, right? And so I think that endpoint is possible for a lot of people if, you know, they make those changes. You know, and I can't guarantee that, of course, but you know, I've seen people improve if they make subtle changes and maintain them, you know? Yep.
All right. So what's the next thing we need to know?
Okay, so we've gotten you got the creatinine, you got the eGFR, we got the urinalysis, which tells you if you have blood or protein. Then I would even go far enough to say with the protein, you can ask them to quantify it. Okay, you can quantify how much protein you're losing. Okay, so just so you know, the more protein you're losing in your urine, the more protein you're losing, the more damage is being done to your kidneys. Okay, so you can actually ask them to do what we call a urine protein creatinine ratio, which will kind of give you an idea of how much protein you're losing in the urine. And that could be in a normal day, a normal person like myself, we're losing less than 200 milligrams or less in a day in your urine. 200 milligrams of protein is lost in my urine, less than that in a day. Okay, now you want to know if your loss of protein is more than that. So I've seen people lose, 500 milligrams, 1,000 milligrams, 3,000 milligrams, which is 3 grams, 5,000, 10,000 grams. So the more protein you're losing in your urine, the worse damage is being done, and the more damage is being done to your kidney, and the less likely you're gonna have with those kidneys. Do you see what I'm saying? Because your kidney function eventually is going to decline.
Yeah, I think mine was only like 800 or 900, and I thought that was high.
No, it's not. So there's a range where you get what we call nephrotic when you lose about 3,500 milligrams of protein in the urine, and at that point you're losing so much protein that your blood pressure is getting higher, that your lipids are getting off the charts, that you're getting swollen, short of breath, all these other things that happen. So the more protein you're losing, the more damage. So again, that gives you a sense of control too, right? So how much protein am I losing? How much protein am I losing? And now you can do the urine spot creatinine ratio. The other thing you can do, and maybe you've done this before, is the 24-hour urine. Have you done a 24-hour urine before?
Yes.
Yeah, it's a pain, right? Completely pain. So we're talking about eGFR and we're talking about protein loss. You can do spot checks on them with the blood and the urine, but the most accurate way is to do a 24-hour urine where they collect your urine over a 24-hour period. And when they collect that urine over a 24-hour period, they're able to properly assess not only how well your kidneys are functioning, but also how much protein you're losing. Mm-hmm. And that calculation of how well your kidneys are functioning is not eGFR, it's creatinine clearance, which is a different way of measuring it. So with a 24-hour urine, you'll be able to get creatinine clearance, which is a percentage of how well your kidneys are working, and quantify your protein in the most accurate sense. But it's also very cumbersome to do. Imagine going to work and you got to carry a bucket of urine with you and keep it cool next to your Kool-Aid in your fridge. So it's like a little bit more. I don't do it all the time. I do it sometimes, but those are other ways you can quantify that protein.
Yep. All right. So what's next? We got, it's hard to remember everything we just did.
You got the creatinine, you got the eGFR. That's what you want to know. You want to get a urinalysis, a urine protein creatinine ratio. And if you really want to get diligent, you can get a 24-hour urine on you, which can tell you the creatinine clearance and protein. Okay. Now, with those being done, my baseline workup is, let me tell you this, my baseline workup is a renal panel, which is BUN creatinine and EGFR,
Yep.
a urinalysis, a urine protein creatinine ratio, and lastly, a renal ultrasound. So get an ultrasound of your kidneys, okay? And what the ultrasound is going to do is they're going to tell me, are your kidneys nice, plump, and juicy, or are they shrunken little prunes, okay? If they're shrunken little prunes, there's not much I can do for them. That means they're shrunken little prunes. That means they're scarred up. Okay, it's called echogenicity. They're very echogenic on the ultrasound, meaning they're scarred up. If they're scarred up, the nephrologist really can't do much for you because it's late stage. You see what I'm saying?
Yep.
If they're nice and juicy, you can consider what we call a kidney biopsy, right? You can consider a kidney biopsy, and that's another option, of course.
Yeah, and so I know when mine were done, they were scarred and smaller than what they should have been. I didn't get a copy of the ultrasounds, but boy, I remember getting a lot of ultrasounds, and I had a dry cough that just would not stop.
Go away.
And even holding my breath for 10 seconds was next to impossible. And I remember the ultrasound techs, I'm sure they were just ready to like sedate me or something because I couldn't stop coughing as you're laying there and they're doing it.
So when the kidneys are scarred, like you said yours were, sometimes your the nephrologist will recommend not getting a kidney biopsy, because a kidney biopsy, what that entails is them taking a needle into your back directly into your kidney. Yep, and now I did not get a biopsy. Yeah, it's a vascular organ, and if it's scarred up, a scar does not heal as well as, say, regular tissue. So if you poke a needle into a scar, you can actually bleed out a little bit in your kidney. So you don't want that to happen. So a lot of times when I've seen those people with small kidneys, I don't opt for the kidney biopsy right off the bat.
Now, what all do you learn from the biopsy?
So the biopsy is going to tell you what pathology, what is actually going on in your kidneys, right? Now, let's just say this, okay? So when I get my workup back from the person, we're getting labs, but you're really looking at the human being themselves, right? So if you were a healthy 40-year-old male, had no history of anything, like you worked out, not even worked out, just a regular dude, right? No diabetes, no high blood pressure, no use of any NSAIDs or ibuprofen, Aleve, Advil, those kind of things, and you were normal, but those were normal, your history is normal, but you had a lot of protein in the urine, I'm concerned. I'm concerned. But if you were a 45-year-old, 50-year-old with diabetes for 20 years, not controlled, I'm concerned. But I have a diagnosis in my head. Hey, there's diabetes in his kidney. Do you see what I'm saying? Yep. So that's how you kind of properly assess somebody. Now, depending on the level of protein, and depending on the level of blood in the urine, you would make a call. And what we do is get what we call a serological workup, which is ruling out what we call any autoimmune diseases. Okay, autoimmune diseases mean your body is attacking itself,
like lupus. Yeah.
Yeah, so you want to rule those out. So if you have a large amount of protein or blood in the urine, you may want to ask the nephrologist, hey, did you do a serological workup, which is, all ANAs or what we call lupus workups and all these other ones, just to make sure that's not the case. Unfortunately, in San Antonio, so many people here are just obese and diabetic. So a lot of times my presumption is diabetes, but oftentimes you can have other things going on. So you check those serological markers just to make sure. Now, if those serological markers come back positive, like for lupus or some other disease, or if they come back negative and there's a ton of protein in the urine, I may just go for a biopsy. And the biopsy is literally going to take a sample of your kidney out. It takes a little sample of your kidney out. They look at it under a microscope and they say, this is the disease process that is going on. And the reason why I know that is because different disease processes have different treatments. If it's just diabetes in the kidney or high blood pressure in the kidney, the control is control your diabetes, control your high blood pressure, right? That's what you're going to do. If it's lupus, guess what? I got to start immunological agents, right, to suppress your immune system. Or if it's IgA nephropathy or these other things, then I can kind of figure it out. So that's why kidney biopsy may be crucial. We don't do it in everybody. That's what I want you to understand. If you're a kidney patient out there and you haven't had a kidney biopsy, it's not like your nephrologist is doing job. It's just clinically he or she may have seen you and said, hey, dude, you've been at diabetes for 30 years. You have no toes. You went blind. You have all these other issues that are going on.
Pretty easy to connect the dots.
Exactly. So, but if you're a healthy 40-year-old or 50-year-old, nothing else wrong with you, have blood and protein in the urine, I'm sticking a needle in there just to see what's going on to rule out anything.
Yep. And if a person does have smaller kidneys than normal, but they look okay, they're not scarred up, do they have to do things differently for them? Because we've had a few people mention that their kidneys are smaller than normal.
Yeah, so it depends. So like I would not just ask about how small the kidneys are. I would ask like, are they scarred up? Do you see what I'm saying? So normally your kidneys are supposed to be 12 to 13 centimeters big, like a healthy kidney, 12, 13 centimeters. Sometimes as we age, they naturally shrink down. Do you see what I'm saying? So if your kidneys are 9 to 10 centimeters, that's kind of small, yeah. But you may want to ask the nephrologist, is it scarred up? Does it have what we call echogenicity, which is like scarring changes on there? That tells you if it's healthy. And again, if your EGFR and creatinine are normal, then you're pretty normal. Now, I have seen people that have born with small kidneys, and over time the disease just gets worse and worse, and they go down. So that's where you have to connect the dots, right? Connect all the things like EGFR, creatinine, protein in the urine, kidney size, and then go from there.
All right. So what's next? Now we know what our kidneys look like, and hopefully the cause, or at least what path I guess to take for the treatment.
Yeah. Then, okay, like not the magic bullet, but what we do for a lot of people is put them on two types of medications, either ACE inhibitors or angiotensin receptor blockers. Okay, ACE inhibitors, they're kind of in the same pathway. And what these medications do, they're actually blood pressure agents, right? They control your blood pressure. But what they have been shown to do is ACE inhibitors and ARBs is decrease the amount of protein in the urine. Okay. So what's great about that is, so you can take someone who has significant amount of protein in the urine, say 3 grams, and maybe bring them down to 2 or 1.5 grams by maximizing that kind of therapy. Do you see what I'm saying?
Yep.
You're controlling blood pressure and you're decreasing the amount of protein spilling. But again, remember, the amount of protein you're spilling is directly correlated to how bad your outcome is going to be. So if you're spilling a lot of protein, that's a bad thing. So that for sure, you got to make sure that you are an ACE inhibitor or an ARB. That's what I would ask your nephrologist. Am I on those? Now, there's some people that have contraindications to those, and just so you know, those medications can oftentimes raise your potassium a little bit, and that in itself kind of limits how much we can use them. Maybe we have to put you on a lower dose instead of a high dose because your potassium goes high. But that's one of the rate limiting kind of steps. Also, some people are allergic to those medications, so that could be a reason why you're not on it. But definitely ask your nephrologist, ACE inhibitors and ARBs.
And if I looked at my blood pressure medicine, how would I know if it's one of those two?
ACE inhibitors end in pril, P-R-I-L, whereas ARBs end in artin, so losartan, candesartan, so they end in ARTAN. So that's how you would know those two medications.
I'm looking at mine right now. Neither of mine are that.
Oh, is that right? Really?
Yeah, I have amlodipine.
That could be a contraindication. You know, your potassium may have been on the higher side. Now,
no, my potassium was critical low, and they gave me 2 bags of it, and then almost the entire time I was there, I had it added to my drip, and they had me eating potatoes in the hospital and told me, eat potassium when you go home.
Every time is different. So you got to remember, so your nephrologist, you may want to look at what your potassium is. So I sometimes don't start people on ACEs and ARBs if their potassium is on the higher side. So a normal potassium, for those of you lab people out there, is between 3.5 and 5.2. So 3.5 and 5.2. And if my patient's potassium is like 4.7 or 4.8 or 4.9 or 5, I may not put them on an ACE or an ARB because their potassium will go over the edge. Do you see what I'm saying?
Yep.
And then high. And so that could be a reason why you're not on that. You may want to ask your nephrologist, why are you on those medications? Why you're not on those medications? Because they are beneficial to your kidneys.
Yeah, I'm trying to find where my potassium is. Well, here it is. My potassium, my last one, 4.6. So I'm doing good.
Yeah, it's normal. It's in the normal range.
Yeah.
But you may want to ask your nephrologist. I'm not trying to tell anyone here what to do, but ideally, that's the kind of medication, kind of the basic of what we do is to make sure you're on that. So
yeah, well, I've been wanting to talk to my doctor about my blood pressure meds just because I've gotten used to taking them, but I take some in the morning and some in the late afternoon. The late afternoon ones knock me out, and the morning ones, right? Yeah, I think it's clonidine. Yeah, clonidine. That one makes me tired. I'm pretty sure it's that one.
The other thing y'all should learn how to do is pronounce your medications. Just work.
I butcher all of mine.
I'm kidding. I can't. Sometimes I can't spell it just to sound out these medications. Too,
I can pronounce one of them. 81 milligram aspirin. That one I can pronounce.
That's an easy. That's a cheat. Come on, dude.
All right. So now what's next? So we're looking at those two medications. Are there other medications that you may prescribe?
So the main thing is that you have to look at what the etiology or the cause of your kidney failure is, right? So if it's so let's just say in your situation, they did the biopsy and they found something related to the NSAIDs, which is acute interstitial nephritis that can happen with ibuprofen and Advil. I would stop those medications, right? Stop those medications. Also, if just so you all know, everyone out there who has kidney disease, you should not be on an NSAID for a long period of time, particularly ibuprofen and Advil. Typically, we tell them, hey, Tylenol is safe for you with kidney disease. So that's the medication, over-the-counter medication of choice for pain relief. You see what I'm saying?
Yep.
So avoid those NSAIDs. Now, if you need stronger medication than Tylenol, you may want to ask your primary doctor if they can give you something more prescribed for the pain, like you have severe back pain or something. But generally stay away from any medication that can hurt you. Regarding medications that can hurt you, if you start a new medication, let's just say you started a new medication, right? And you were and it's from a PCP or it's from your ER doctor or something like that, I would always call your nephrologist office and say, hey, I just started this medication. Is it safe for my kidneys?
Yeah.
Okay. So I would ask the primary doctor and the ER doctor or whoever gave it to make sure of that. But you got to remember, certain medications can't be given with people with kidney disease. And certain medications can be given, but at lower doses.
Yep.
So
the renal dose.
Yeah, the renal dose. Exactly. So you may not need 800 milligrams twice a day of that medication. You may need 400 milligrams once a day. Do you see what I'm saying?
Yep.
So it depends on the medication there. So you got to make sure to avoid medications that can hurt your kidney. That's kind of crucial. That's one of the things. So, yeah.
Oh, go ahead.
No. What I was going to say is after you get rid of all the medications that can hurt your kidneys, I would then you have to decide what caused the kidneys to go down. If it's diabetes, you got diabetes and high blood pressure. That's the biggest ones. Everyone's like wants a magic bullet, but you got to control your diabetes and high blood pressure. I'll be honest with you. That's the thing. And the thing is, like, you got to take your medications, but you got to do what you did, James. You got to lose some weight. Yeah.
And I still got a lot more but my doctor, so I was not diabetic, but I was pre-diabetic. I'm pretty sure I really was diabetic type 2. I just never got my blood sugar checked. I was a walking candy store. Loved my sweets. But after not eating for over a week, I couldn't keep anything down. Before I went into the ER, I was classified pre-diabetic. I think my blood sugar was 130 something like that. And it probably should have been a lot lower if I was healthier. Yeah. But now I manage my blood sugar. I watch what I eat. I actually kind of don't go crazy with the carbs. I get plenty of fiber. And my last A1C was 5.6. So great.
That's amazing. Yeah.
Fantastic.
Yeah. So, and again, like, I don't think people realize, I've seen many patients that are diabetic and high blood pressure lose weight and come off or decrease the doses of those medications. I've seen that numerous times. Unfortunately, it's not in the sense that of people like you who take their health on themselves and make the changes. Unfortunately, where I really see that is when these patients get really sick in the hospital, and they get in the hospital, they're there for 2 weeks and they lose 30 pounds. You see what I'm saying?
Because they're there and they're forced to eat healthy.
They're forced to eat healthy, but also sometimes the stress on their body causes them to lose weight. They're in the ICU or whatever it is, and they lose 20, 30 pounds or 40 pounds in the hospital because, again, they're not eating as much, but they're just, the stress of everything, and they lose all that weight. And then guess what? When they go out, they're on lower blood pressure medications. They're all off of them. They're on diabetic medications. But again, that's where I predominantly see the people lose weight. Now, I wish more of my patients were like yourself and lost the weight healthy. But I've seen that with people with healthy people lose weight. So that's another thing. So
yeah, my doctor is so big on my weight, and I need to get a refill of my blood pressure medicine. They're only good for 90 days, and I'm going to have to call. And my scale is Wi-Fi. He knows my weight every day, and I know he's going to look at it.
Yeah,
I'm going to get talking to.
He's gonna fat shame you.
Yes. He's like, I'm holding steady, which is great. I'm holding steady. I'm not supposed to be holding steady because I gained that COVID 30 and I'm holding on to it.
COVID 15, sir. You went over. You got pregnant. You got pregnant.
COVID 40.
Yeah.
I was boosting it to 30.
Yeah.
Now, someone asked about here. I hear about this medication all the time in a lot of the groups. I'm going to butcher it. Prednisone. Hey, I was close. I hear a lot of kidney patients being prescribed this, and here someone's asking about for gout possibly.
Okay, so prednisone itself, is given typically in those people with autoimmune diseases, right? So what prednisone does, it's a steroid, and that steroid is anti-inflammatory. It stops inflammation, and an autoimmune disease is typically inflammatory and causes inflammation. So like the lupuses, but there's all these other what we call vasculitises, which are like inflammation of blood vessels, and we give the prednisone to kind of offset that. Also, people who get kidney transplants, because they're they can have higher inflammation, they're given prednisone to prevent rejection. Now, as far as gout, yeah, sometimes in the short term, if you're having a severe episode of gout where it's just hurting, right? It's just hurting, they may put you on a short course of prednisone to kind of relieve that kind of inflammation in the joints. Do you see what I'm saying?
Yep.
So some people are on prednisone, so it's not for everybody. Again, that's where a kidney biopsy kind of comes in handy. You see what I'm saying?
Yep.
That's where biopsy, you know that, hey, I need autoimmune medication.
Yep. Now we have a question here. I saw a few people who have asked this question, and it kind of goes back to blood pressure medicine. A lot of us are on a low dose aspirin, an 81 milligram aspirin. But yeah. I get a lot of comments from people who are afraid, like, should I stop taking it? I, of course, say, talk to your doctor. I'm a stranger on the internet. I can't tell you to stop taking a pill.
So I actually made a video about this called over-the-counter medications and kidneys or whatever. You can check that out. And I typically are against NSAIDs, non-steroid anti-inflammatory drugs, not against them, but overuse of them. Okay. I made the exception for kidney patients never to be on them except for aspirin, 81 milligrams. So aspirin 81 milligrams has been shown to prevent heart disease and prevent clotting in the blood vessels of the heart. Okay, 81 milligrams shouldn't hurt your kidneys. If you're on the high dose 325, that can hurt your kidneys every day. Do you see what I'm saying?
Yeah, that's a lot.
Yeah, so I would do the 81 milligrams. That's the safe dose, the baby aspirin, if you will. You got to remember, people with kidney disease don't die of kidney failure. They don't die of kidney failure. They die of heart disease. They die
right here.
Why they're putting the aspirin on you, because they want to prevent that heart disease or make it a little bit better. So that's what they're trying to do with aspirin, is just make sure that you don't die of a heart disease. Okay.
Yep. Now the prednisone, did I say it right?
Yes, you got it, sir.
Awesome. Does it make you more susceptible to getting an infection?
Well, high doses of steroids, yes, they can. Depends, on the dosage of it. But yes, it can. It also can. When you're on prednisone, it leads to weight gain. It leads to diabetes, worsening blood sugar control. It leads to higher blood pressure. So that's why you want to be on a very minimal dose. The people that are on it are usually on 5 milligrams or 2.5 milligrams a day. So they're on very small doses. Now, sometimes like in a gouty flare-up, or if you had, let's just say, really bad allergy season or something, they start you on a Medrol dose pack, which is a higher dose, like 40 milligrams or 20 milligrams, and then they taper it down. But that's only in those kind of acute settings. Maintenance-wise, you're on like 5 milligrams a day typically. Awesome.
Now, I am shocked that this question has not appeared, so I'm going to ask it. It is a pill question. This is one that just drives me nuts. Only because so many people abuse this to try to get views on YouTube. What about sodium bicarbonate?
Sodium bicarbonate is as far as what? Why are people on it? Is that what you're saying?
Yeah, when are they typically prescribed? Because a lot of people, and this is what bugs me, is they make these videos, 5-minute cure, and they're telling people practically to eat boxes of baking soda. And I've actually had people tell me they're doing it, and it just shocks me. It's like, that's so bad for you. That's not what it's meant for. Can you address, in case anybody out here is thinking like, hey, I'm going to go order some sodium bicarbonate tablets, or I'm going to grab a box of baking soda out of the fridge and fix my kidneys?
So this is the thing. So like baking soda is the poor man's sodium bicarb, right? So for oftentimes when people weren't able, like if they don't have insurance or very poor, or what for whatever reason we ask them to do, they did baking soda in the past. Now the reason why you want to give sodium bicarbonate is typically what happens is with your kidney disease. Like I said, the kidneys are a filter. They clean your blood. They balance your electrolytes, and they balance your pH. Okay, your pH. So the balance between your acid and bases. If you remember high school chemistry classes, you balance your pH. You want your pH at 7.4. Okay, that's where your body is. Now what happens is, in that setting, when your kidneys are not working anymore, they're no longer filtering and cleaning your blood properly and not managing your electrolytes properly, you start to build up acid. And that can be seen on your lab. It's called bicarb on your chemistry panel. And sometimes it's listed as CO2. It's kind of a misnomer, but CO2 bicarb is on your lab. You can ask your nephrologist about it. And ideally, we want that target around 24. Okay, at least above 20. At least, okay, that's where we want it. So my cutoff is usually 20, 21, 22, somewhere around there. And if it's below that, if it's below 20 or below that, we start sodium bicarbonate. And sodium bicarbonate, what it is it's a base. So it offsets the acid in your blood. And when it offsets the acid, it brings your acid levels down. Do you see what I'm saying? Yep. So it's a base. That's why people start it. Now, I think a lot of times they're bringing this stuff up because like alkaline water is really into favor right now. If you're a normal person with normal kidneys, a normal body, you don't need alkaline water. But I have seen some kidney disease patients try it, and it's got a pH of normal pH of 7.4. It's got a pH of 10, which is ridiculously high.
Whoa.
It's supposed to actually offset, or you're taking in bicarb because of it. So I'm not a big fan of alkalizing water, but if you're taking it just for once in a while, that's fine. But that's why people are on sodium bicarb. It's to offset the acid built accumulated in your blood from the kidney disease. That's why you're on it.
Yeah, and if I take,
and it's not a miracle cure, by the way. It's not a miracle cure. It's really offsetting. It's offsetting the acid levels, and by offsetting the acid levels, you are preserving kidney function. But it's just there to offset it.
Yeah, it's kind of to help keep you closer to where you're supposed to be. Now, what if I take too much of that? If someone, and I'm going to be honest, does what they shouldn't do, and they start popping sodium bicarb pills, and now they're getting too much of it. Can that be harmful to them?
Well, you're throwing your pH balance off a bit then. If you're taking too many bicarbonate pills, again, like you can push yourself into, instead of acidosis, you're pushing yourself into alkalosis, which has its own kind of, detriment. So you don't want to be too alkalotic. But what you do is just ask your nephrologist, where's my bicarb at? And you want it ideally at 24. Now, sometimes that's the target we want. But sometimes I don't start sodium bicarb until it drops below 20 or 20 or below. Do you see what I'm saying?
Yep.
And the reason why is not because I don't want to help you. It's just I understand pill burden, right? I understand being on multiple amount of pills is a pain, and it's not convenient, and it affects compliance, right? If you're on one medication, I can expect you to comply, but if you're on 10, it's harder for me to accept that you're going to actually take all 10 medications. So I try to personally reduce pill burden, not overwhelm people. But in general, yes, you want to keep your bicarb around 24.
Yep, I just looked mine up, and it is 26. Yay!
Oh.
I gotta one day look up all my ones from back in the ER. It's on those labs are somewhere on a CD.
Those gotta suck. Yeah, those gotta suck.
They were bad. I remember looking them up and seeing critical on a lot of my labs, just because of how far off they were. And the only thing that was within range was sodium. That was the only one. Because I lived off of Gatorade for like a week. It was the only thing I could consume that didn't make me run to the bathroom and throw up right away. All right, so I'm glad we talked about that, because so many people, I feel, abuse sodium bicarbonate, and think.
I think most of our society right now, like we all want that miracle cure. We all want that magic pill, right? Yep. And so the magic pill is no magic pill. It's actually magic behavioral changes, right? So if you, I'm not opposed to you taking sodium bicarb to, well, in excess, of course, is bad. But if you're making other changes, guess what? You can wind up like yourself and, improve your kidney function, getting more active in your health. Like I've seen this before where people just want that magic bullet. Like apple cider vinegar is the new magic bullet, I think.
Oh, ruin your teeth.
Yeah, but I mean, a lot of them, they could have health benefits. Do not get me wrong, but the way they're used is almost like a panacea for everything. Like it'll fix your kidneys, it'll cure cancer, it'll
grow
make
hair,
give you six-pack abs, whatever. It'll do everything. And I'm like, no, it's you're overstating what it does. And again, I think people rather have the bullet, the little medication or a little supplement or whatever, rather than actually take the effort to make the change.
Yeah, I mean, we all would love to do that. And part of my success that I've had is working with doctors like yourself, listening to them, working with a renal dietitian, and I use apple cider vinegar. I'm not taking shots of it, but I make a salad dressing out of it and I use it because there's certain things that it can help with when part of a balanced, nutritional, kidney-friendly diet.
All right. And again, like this goes to other conversations we had, like incorporate healthy choices all around. You know what I'm saying? Don't just make the apple cider vinegar change. Incorporate other things. Eat more apples. Eat more, broccoli, kale, blueberries, all these other things. Incorporate those, and then you'll have a good outcome. It's not just one little thing. You could die just on taking apple cider vinegar, but if you made all these other changes, you could have a good outcome. Sorry to cut you off, but go ahead.
Oh, no, that's okay. And everyone knows my number one favorite snack. Let's see if people write it in the comment. What's the snack I relied on after I got out of the hospital? And oh my goodness, I ate so
much. Was it Cheetos, sir? Was it Cheetos?
No, that was before. Doritos before. Let's see who says it. There's about a 20-second delay between us talking and people being able to write something. Let's see. If they've been a listener for more than a month, they know what my favorite snack is. And it's something that there are several hundreds types of in the world. And I did not realize that. There we go. Oh, people are getting it. Apples, apples, apples. And right now, guys, I'm here in my office. See?
Apples.
Big old bag of apples. These are all clean. And throughout the day, I eat like 4 or 5 of these a day. I get hungry. Awesome. I need a snack.
I know it's an old wives' tale. Apple a day keeps the doctor away. But I'm a big fan of apples because their glycemic index is kind of on the lower side, but also they have so much fiber to them, right?
Yes.
So I don't think we're talking about gut health. We're talking about bowel movements. I think that's kind of crucial. I think having normal bowel movements on a normal basis is really really healthy. Oh, just so you know, on my side, on my watch party side, Michelle, there's a person here, Michelle. She's asking about rituximab infusions, and she has FSGS. I can't really answer that. I'll be honest with you. Michelle, thank you for the question, but I can't answer questions about your individual management. Although I have used rituximab on certain patients. So.
Yeah. Now we are almost at the top of the hour, so we've talked about medications. Boom, look, we got a whole bunch of Apple icons there. Boom, boom, boom. Awesome.
Yeah.
It's a great snack, and I've come up with so many different ways to make apples so that I have lots of variety. But anything else before we're out of our time here?
Let's see here. Jenny Cool asked me about her GFR, and she said it was 643. I'm like, it's okay, but again,
it's not bad.
I can't give you. It's not bad, but you got to talk to your nephrologist. Again, guys, like I get these questions all the time on DMs or whatever, and I really can't answer for you individually, but just take it to heart that take these questions to your nephrologist. Yeah. Not that I won't answer them in generic form. I'll answer them in generic form. I can't comment to your individual state. So what I always advise people, when you got a question, write it down, put it in your phone, and next time you see your nephrologist or your doctor, hey, I got these lists of questions. And I actually love those questions because they're typically well thought out, as opposed to I'm thinking this, kind of thing. So
yeah. And I'll tell you, so here's how I do it. I get my labs. I either go to the hospital, get them, which then they show up on my phone like 3 or 4 hours later, which is fantastic.
Yeah.
Or I'll go to my primary care physician, my PCP, have blood drawn. It takes like 3 days to get the results, and then they show up on my phone. I do that before all appointments, usually about a week before, get my labs, and then I write up my questions and I think through them. So it may be like, hey, my my sodium, for example, say it's spiked, I may ask, what did I do to do this? What do I need to do to change that and get it back where it belonged? I never have any problem with my sodium. Mine was too low in the beginning because I cut all sodium out. I did not realize you got to get your minimums. There's a minimum and a maximum.
Yeah.
We focus on that maximum. And a lot of times we're like, strip all the sodium. Don't even eat an egg. There's sodium in that. You know, I was like, no sodium whatsoever. And it got too low. Yeah. But I write up all my questions and then I email them to my doctor a day or so before my appointment. And when we're in the appointment, we just go through those and I physically have a printout and I write in my handwriting the answers, which helps me remember it better and helps me listen better. And now I know these are the 5 questions I want to have answered during our time together. We can make great use of it, pop through there, and then they may say, as a matter of fact, and they may add something else to it. And I find it just makes it so much more effective for me. And then all of a sudden I leave with answers and I'm like, yeah.
And I agree. Like I wish more and more people would ask those questions. It actually makes your job a lot more fun when you have intelligent questions to answer. You know, like a lot of times we get this apathetic or just like confused deer in headlights look. And you know, that professionally is just kind of disheartening. You know what I'm saying? Like you want to make a difference in someone's life. And the best way is for you to be engaged and ask the questions. So again, before we go, I think you definitely, again, if you're a kidney disease patient, every time you go see your nephrologist, ask them, what's my EGFR, what's my creatinine, and how much protein do I have in my urine? Those are 3 markers you can follow for the rest of your life as a kidney patient. Because if you see a decrease in your EGFR or increase in your creatinine or increase in your protein in your urine, that's a sign of worsening kidney disease. And so that's something you can track. Maybe even, you know, follow your labs, you know, I'm not saying make an Excel spreadsheet, but
that's what mine are. I put them in Excel.
Yeah, you could follow it and say, hey, my creatinine has been declining. And I actually do that sometimes because if I notice that the creatinine is getting worse, you know, I look at it in the grand scheme of 5 years. You see what I'm saying? I
Where's
look at
the trending?
5 years. It was the trend. So it's like if his GFR went from 45 to 37 over 5 years, I'm like, this is probably progression of your kidney disease. You see what I'm saying? Over 5-6 years. And sometimes you can see it even more rapid. The last thing before we go, if your GFR is less than 30, then you need to talk about dialysis access and different things like that. And that's something we discussed last week.
Yeah, we had a few weeks ago. I think last week was the cost of kidney disease.
The cost of kidney disease, yeah. So 2 years ago, we talked about dialysis and all those modalities. So GFR less than 30, you got to start talking about dialysis. GFR less than 15 is when you're talking about going on dialysis itself. So those are different talks at different stages. So
yeah. Now here's a great question that was asked in the very beginning, and I'm glad they popped it up here again. If you had to give like your top 3 tips for a person, what can they do to help their kidney health? If you and I just met, what are like we kind of mentioned a few things about blood sugar, blood pressure, losing weight, but what would you say are like your top things that you would like all kidney patients to do?
First off, like I said, get educated. Educated is key. Then once you get educated about kidney disease itself, get educated about health as a whole. How do you make those changes? How do you implement those changes? About healthy diets. I would definitely ask them to do that. So educated about kidney disease labs, educated about health as a whole and diet, what's good there. And then start implementing behavioral changes. And then once you start making behavioral changes, then you'll start to see different outcomes. Now you got to remember, if you have diabetes, high blood pressure, or other diseases, make sure you take your medications all the time. So that was the top 4, I guess. But you know, those are the kind of key things. Education is key to me. Like if you don't know what's going on, you can't help yourself. So educate yourself about kidney disease, educate yourself about health, implement those behavioral changes, and then control any disease you have, the diabetes and high blood pressure that's doing the damage.
Yeah, and I would encourage everyone, all those I agree 100%, and I would encourage everyone, if you don't think you have the motivation to make those changes, find something to motivate you. For me, it's my kids. I got 2 little tiny kids. I want to be running around the yard. I want to have high energy. I want them to know me as not having anemia, not being
Yeah.
tired all the time, not recovering from a dialysis treatment. I still want to be able to just go out and do everything and enjoy life. And when I was laying in the ICU, I really thought about that. And it was my kids. It's like, oh, I got to do this for them, not for me. I got to do it for them. And that's what kept me going.
So I'll take it beyond that. I think health for your kids is important because you want to be there later in life. But I also think, people are obsessed with living longer, but I think you have to be obsessed with living better. So I don't, I've seen so many people that reach 70, they're in nursing homes, or they have amputations, or they have a stroke and they're immobile. Like, I want to live the last few years of my life healthy. I want to be traveling. I want to be even working maybe, or, like you said, hanging out with the kids.
Exactly.
So it's not, you want a good lifestyle, a good life. And I think so many people are stuck in a rut where their health is so deteriorated that they're almost like, like totally out of it because of it. They're just disgruntled at this point. But if they started making those changes, and once you see that first 5 pounds come off, you'll see how much better you start to feel. So
it's like a snowball. It keeps getting more and more powerful as you make these small progresses. It's one small step, but they quickly add up. And just like I mentioned earlier in our conversation, there was a point, I was making these small steps, making a little progress. And there was a day when I realized, holy cow, I've come so far. I feel amazing. And I agree. I started jogging after that. Before, getting from the bed to the bathroom was difficult because the anemia, just catch my breath, going and checking the mail. And guys, I don't have a mansion. This is a small little house. The mailbox is right out there. I could see it. I could throw a baseball and hit it.
Where does your butler live exactly then?
Oh, he lives in the West Wing.
Next to the helicopter pad, right?
Yeah, exactly. Right below it. But, when I made those small steps, and I had to keep thinking of my future, my children's future, and I wanted them to learn to eat healthy and not have to have these problems in their lives. And one day I kind of realized I've made it so far. Holy cow, life is so much better. And I thought I could never give up fast food, Dr. Pepper, eating giant pizzas for a meal. All that stuff. Before any of this happened, I would have told you it's not possible for me. This is the way I am. I'm going to die this way. There's no changing it.
Yeah. No, I agree. Like, if small, subtle changes over long periods of time will have drastic effects. Like, unfortunately, now we're living in a society where everyone wants things now. So they'll implement CrossFit or they'll implement keto for like 3 months, and then they think it's going to have a result. I'm like, no, that's not going to do it. So small changes, just stop that bag of potato chips every day. Stop that soda every day. And all of a sudden you'll see weight coming off, and so that's how I view it. And again, we talk in health topics a lot, you and me, but again, the general health affects your kidneys. The kidneys are the canary in the coal mine. Oftentimes they reflect what's going on in the body.
Yep. All right. I want to thank everyone who is here. If you have not done so already, click the subscribe button and make sure. And there's a link in the description below this video. Go over and subscribe to Dr. Butt's YouTube channel, his Facebook channel, and I always get it wrong. Your kidneys, your health, correct?
Oh my God, you got it right.
I got it right. Always reverse it. I was thinking it. I was thinking in my mind. I was like, get it right before you get to that part of the sentence. Yeah. You can almost see me thinking of it. Oh, what's the order? I got to get it right. Yeah. All right, everybody. We will be back here. I'm, of course, back here next week. Dr. Butt will be back here in 2 weeks, every other Wednesday, with lots of great topics. The schedule's on Dadvice TV of when we'll be here and what we're talking about. Please share this content, share these videos. Let's get the word out so more people can live a great life with kidney disease. Kidney disease does not need to hold you back, and it doesn't define you. When you're educated, you learn about it. You can make the right choices. That's kind of how I look at it. I'm not on a renal diet. I'm just making smart choices. Life can, for many people, be so much better and he just happened to have kidney disease. All right, thanks everybody, and we will see you in the next video.